Good evening, everybody. On behalf of the organizing committee, I welcome you all for the webinar on this World Anesthesia Day. Now, I request Dr. A. Arun Prasad, Organizing Secretary and Resident Veterinary Officer and Head, Resident Veterinary Services Section, to welcome the gathering.
Good evening and welcome you all to this World Anesthesia Day, commemorative global webinar on critical care anesthesia in trauma critical care emergency. On behalf of the Institute and warm welcome to our Honorable Vice Chancellor, Dr. C. Balachandran sir, for kindly accepting our invitation and consent to deliver the special address on this World Anesthesia Day. I take great pleasure in welcoming our international speaker, Dr. KIRK MUNOZ, MRCVS, cVMA, Diplomate ACVAA, Veterinary Anesthesia and Analgesia, Board Certified Specialist in Veterinary Anesthesia and Analgesia, Assistant Professor, College of Veterinary Medicine, MSU, Michigan State University, USA, who has accepted our invitation to deliver the webinar. Thank you. We welcome you, sir. I heartily welcome the faculties, organizers, co-organizers, and the staff of TANUAS for joining us in this webinar. I am profusely elated to welcome our participants from all over the world. So more than 30 overseas countries worldwide have joined us in this webinar. So I am so elated to see that 31, including India ourselves, they have joined this webinar. So I truly believe that this webinar will be a much fruitful and productive in the state of anesthesia and critical care. So until one loved an animal, a part of one's soul remains unawakened, by Anatole France, who has said that. So I welcome you all, one and all, again. Thank you.
Thank you, sir. Now I invite our Honorable Vice Chancellor, Tamil Nadu Veterinary Animal Sciences University, Dr. C. Balachandran, to deliver the special address.
Yes, good evening from India, and the guest speaker, Dr. KIRK MUNOZ, the organizing secretary, Dr. Arun Prasad, co-organizing secretary, Dr. Vijay Kumar, Dr. Ramesh, and the team, and all the participants. Greetings from Tamil Nadu Veterinary and Animal Sciences University, and also greetings for the World Anesthesia Day, which is celebrated in commemoration of the successful public demonstration of the efficacy of inhalation of ether vapor as a means of overcoming pain of surgery on this date in 1846 by William Thomas Green Morton at USA. So he is considered as a pioneer of ether anesthesia in man, and he has also experimented with the animals, and considering that seat of pain is the brain. So this is, with this idea, he has done that one. So after doing the experimentation laboratory animals and dogs, which he is able to construct anesthetic mask and carried out ether experiments on himself. So that is what has happened. So, and Morton gave the first public demonstration in the ether dome in Massachusetts General Hospital in Boston on the Friday, 16th October, 1846. And discovery of inhalation anesthesia was the most important medical discovery of the 19th century. And it was due to the efforts of Morton to get the recognition and the news on the painless surgery spread to entire Europe and even India soon after the ether day. So in India, the pre-ether era, it is beginning from Sushruta, when in 500 BC, operations were performed using opium, wine, Indian hemp, and of course, by tying up. The first administration of ether anesthesia in India was done on Monday, 22nd March 1847 in Medical College Hospital in Calcutta. And of course, John Snow popularized the obstetric anesthesia by chloroforming Queen Victoria for the childbirth. And in 1888, Edward Laurie in Hyderabad has administered chloroform anesthesia to 40,000 people without a single fatality and formed the first Hyderabad Chloroform Commission. The first woman anesthetist in India and perhaps the world, Dr. Rupa Bai Kardunji. So she was working under Edward Laurie in Hyderabad. And within a year, the ether had been administered to most species of domestic animals. So from the case of X1 to the use in the domestic animals has started, and veterinarian published an article on this way. And even our Mahatma Gandhi, under trying situation, underwent appendicectomy with the chloroform use, and done by Surgeon Colonel Maddox. So the first reported veterinary use of chloroform was the reference by Goodwin, a veterinary surgeon, to Queen Victoria. And there is a vivid and detailed description in the Veterinarian in 1848 in an editorial by Percy Wall. So chloroform was given by means of a sponge in a common leathern mask, and it would appear that the first report of anesthesia in the horse was that of Ruini in 1550. He administered the belladonna alkaloids mixed with distilled endive or barley water with the feed, as a result of which they slept for a day. So in 1950, Hobday published the first textbook completely devoted to veterinary anesthesia. And in the late 60s, the first alpha-2 adrenoreceptor agonist, xylazine, was developed for use in ruminants and later extended to other species of animals. In 80s, we could see three further compounds in the group, ditomidine and romifidine, for use in horses, and mediditomidine and its reversal agent, the alpha-2 adrenoreceptor antagonistic atipramazole, for use in dogs and cats. So many things, glimpses are given in anesthesia, and isoflurane is now used, that is introduced in 1980s, and in the early 70s we could see the ketamine introduction, and as a successor to phencyclidine, and in 1980s, non-barbiturate intravenous agent propofol was introduced, mainly as an induction agent. So this a day which is concerned with the trauma and emergency care. So there, with regard to anesthesia, they have given the term safety means safe anesthesia for everybody today. So the role of anesthetist is equal to that of surgeon in saving life of ailing patient. So this trauma and emergency care is primary or first care of patient requiring immediate care, which differs from routine veterinary service. The range of clinical issues potentially seen in the trauma patient span all systems and frequently necessitate a risk-benefit assessment in a systematic manner in order to optimal manage a complex patient. So the basic principles, including aseptic technique, consent, environment, safety, and additional equipment, ultrasound in anesthesia, and intensive care, and cardiopulmonary resuscitation. So the way it goes, and it has been used as will be given description of this under various conditions which require the use of anesthesia. And TANUAS is the pioneering veterinary university in Southeast Asia to start offering a unique course on veterinary anesthesiology since 2017. And hence, the purpose of this World Anesthesia Day 2020 commemorative webinar on anesthesia in trauma, critical care, and emergency in small animal practice is to impart quality online update to the veterinary graduates, postgraduates, faculties practicing or field veterinarians. So that way it will aid in
Thank you, sir. Now I invite Dr. G. Vijay Kumar, Co-Organizing Secretary and Professor and Head Veterinary University Peripheral Hospital, to introduce the speaker to the webinar.
Thank you. Dr. KIRK MUNOZ graduated from the University of West Indies in Trinidad and Tobago, West Indies, with a DVM degree. He worked for a couple of years at the University of West Indies. He completed anesthesia residency at Michigan State University, Michigan, USA, and became a diplomate in veterinary anesthesia and analgesia. He is also certified in veterinary medical acupuncture. Currently, he is an assistant professor at the College of Veterinary Medicine at Michigan State University. His responsibilities at MSU include performing anesthesia in the small and large animal hospitals, as well as assisting some of the surrounding zoo with anesthesia on their animals. His other responsibilities include teaching preclinical and clinical students, as well as being a primary investigator in research and working with other departments and researchers at MSU. So over to Dr. MUNOZ, who has readily accepted for this webinar. Please, we are waiting for your webinar. Dr. MUNOZ, please.
Thank you very much.
Yeah.
Thank you. So thank you to everyone for that warm welcome. Good evening, good morning, depending on where you are. It was a great honor to be asked to present here today at this conference, this event. Can everyone see my screen okay?
Yeah, fantastic.
Okay, thank you. So as we said previously, so we can get going here. So today I'll be speaking about anesthesia and trauma, critical care and emergency in small animal practice. So as you can well imagine, there are a lot of different topics we can cover if we want to talk about, in this area, so which would take us quite a while. So I thought I would focus on these 5 topics. So we're going to talk about C-sections, management of neonate, hemorrhage, brain lesions, and automobile accidents, primarily associated with fractures. A lot of these topics, the kind of anesthetic preparation can overflow into some other topics. So I will try to, just discuss a little bit some other things we can take into consideration as well if we want to talk about other conditions that are not listed here, just because there's so much information that we could deliver in these areas. So before we even start talking about these topics, what is very useful, and I think is something that should be used for basically every single case, is to have a checklist. So you want to know what's the patient's signalment, and why is this important? Because some breeds may have particular concerns over others in terms of drug use, example. So collies, you want to be careful with drugs such as azithromycin and butorphanol. You want to get a thorough history on your patient. Why is this relevant? Because these patients may have certain conditions that could affect the anesthetic event. Even it will also affect what drugs we're going to use. So a thorough history, has this animal had a reaction with a drug previously? What problems has this animal had? Does this animal have something that a gene defect that we need to know about? Physical examination. As I tell my students, no protocol, anesthetic protocol, should ever be created for any animal until you've met that animal, until you've reviewed their full history and done a physical exam of that animal, because you may miss things that are really relevant for the anesthetic event. So physical examination, for example, you examine a cat, and this cat has HCM, so hypertrophic cardiomyopathy. Is that going to be significant in our drug selection? Absolutely, because a drug such as ketamine, you may want to avoid ketamine in a cat that has HCM. However, dexmedetomidine may be a favorable drug for that patient. So physical examination is key when you're examining your patients. Appropriate blood work, again, necessary for all your patients. You may have a very young patient, maybe a 3 or 4 month old patient that comes into your practice for a procedure. Probably not always indicated to do a full panel blood work on those patients, but at least a PCV, packed cell volume, total solids, or total protein is going to be important. And then once you've done all that, then you decide on what diagnostics you need. Do you need to do radiographs? Do you need to do a CT, myelogram, etc., or MRI? Whatever is relevant and necessary for that patient. So having taken all of that into consideration and assessing that information for every one of your patients, now we can move on to our specific topics for today. So as previously mentioned, we're going to focus on emergency C-sections. Now I'm also going to talk a little bit about planned C-sections with an emphasis on dystocias, because for this sort of topic we're talking about today, this event, we want to focus a little more on emergency C-sections, and that will fall under the category of dystocias. So for today, we want to be able to understand the physiological changes that occur during pregnancy, because these are going to definitely affect how we manage these cases. We also want to think about and understand the effects of anesthetic drugs on the dam and offspring. At the end of this, we want to be able to create an appropriate protocol for management of a cesarean section of a small animal. And then we want to move on to understanding what the APGAR score system is. And for those who haven't heard about that system, we will talk a little bit about that as we get on to the neonate section. And then you want to understand how to manage a neonate with a low APGAR score, right? So a high APGAR score is what you want to aim for. If your patient has a low APGAR score, then that's something we need to address. So goals of anesthesia for these cases are essentially, especially in dystocias, to minimize the fetal effects of anesthetic drugs. And also, we need to obviously care about and think about how to provide analgesia for that animal that's actually having that surgical procedure performed. So as we know, basically all of the drugs that we use in anesthesia will cross the placenta. So by knowing this, you know that if you give a bitch that's coming in with a dystocia an anesthetic drug, that drug is going to cross the placenta and it's going to have an effect on the neonates in utero. Other goals of anesthesia, and these goals really relate to any anesthetic event, not just dystocias, not just C-sections. We call them the 4 H's, so hypotension, hypoventilation, hypoxemia, and hypothermia. These things tend to occur basically in almost all of our anesthetic cases, whether they're healthy patients or sick patients. So hypotension, low blood pressure, should be managed appropriately and should be monitored. So you can use a Doppler system, you can use a solometric, or gold standard will be invasive arterial blood pressure monitoring. Hypoventilation, a lot of the drugs that we use will cause these patients to ventilate a little bit less. They're not able to breathe as well as they used to because of that suppression. So they may become hypoxemic as a result of that, or their CO2, end-tidal CO2 values may increase. And then hypothermia, so our patients generally tend to become cold under anesthesia. And I just want to draw your focus to this picture for a minute. You can see this cat on this black pad. That's a hot dog blanket, or hot dog. And what this does, it actually provides heat to that patient during anesthesia. And another thing we need to remember is that patients start to lose body heat at pre-med. Not at induction, not during the procedure, not at the end of the procedure. The time that they start to lose heat is when you actually start with that pre-med. Okay, so our goal really is to try to maintain their body temperature versus try to correct their body temperature. It's a lot more difficult to get an animal from a low temperature to a normal temperature versus trying to maintain that normal body temperature. So, just to focus a little bit back more onto our dystocia, remember prolonged delivery prior to delivery causes maternal physiologic compromise. And this can result in fetal depression because if that animal has been trying to deliver these puppies for a while, you can get that placental detachment and perfusion and delivery of nutrients to the puppies or kittens in utero will be compromised. Hypoxemia, because that cross again of nutrients and oxygen to the puppies may be compromised, and acidosis can also develop. Maternal and puppy mortality is significantly increased during emergent versus planned C-sections because, again, in C-sections, you've got time to plan for these events. These are usually elective C-sections. Whereas for emergent cases, such as a dystocia, it's usually animal appears at your door, animals has been in labor for a while, puppies are in distress. We need to get these puppies out quickly or kittens out quickly if we're going to save their lives. So mortality rate is usually higher for these emergent cases. Timing and preparation are extremely important for survival, both elective and emergency sections. If you know you're in a practice or an area where you may have these cases kind of pop up at your door, you really want to have a station ready. You want to maybe have a protocol set up that can be modified to suit that patient, but at least you have a baseline where you can begin with these cases. Another reason why we are concerned about these dystocia cases is because when you assess these animals, you do an ultrasound perhaps, and you look at the heart rates of the puppies or kittens. If they're bradycardic, it usually indicates myocardial hypoxia, right? That's usually the main reason why these animals in utero are bradycardic, because the oxygen needs are not being met. So you may think, well, let's give them an anticholinergic to help correct that problem. Glycopyrrolate, as we know, does not cross the placenta. So if the bitch is bradycardic, you want to treat that bradycardia for whatever reasons if you think is necessary. I would usually go towards glycopyrrolate to administer to these dogs, because I know glycopyrrolate will not cross the placenta. Atropine will cross the blood-brain barrier. It will cross the placenta. So atropine has been found to have little effect on heart rate in puppies until they're about 14 days old, and kittens about 11 days old. But if there's an effect, if it does cause an increase in heart rate, remember that increase in heart rate is going to increase the myocardial oxygen demand. These puppies or kittens were initially bradycardic because their myocardial oxygen demand was not being met. So by giving atropine to these cases, you could actually make that condition worse. And the amount of oxygen that they need will increase because the heart is being made to work harder, potentially, and that demand would not be met. That's why they initially came in bradycardic. So glycopyrrolate may be the better option if you think the bitch or the queen's heart rate needs to be increased without affecting that of the kittens or puppies. Now, we're going to focus a little bit on some other systems in these animals. Because of time constraints, etc., I can't go into too much detail, but I just want to touch on these areas just to make them, most prominent in your mind. So we're going to look a little bit at the cardiovascular system, respiratory system, and gastrointestinal or GI system. So remember that up to 25% of cardiac output during pregnancy goes to uterus and placenta. Again, just to jog your memory, cardiac output is equal to heart rate times stroke volume. So if any of those things are compromised, as in your heart rate or stroke volume, cardiac output is going to be affected. Cardiac output usually increases by 30 to 50% in response to increased blood volume and decreased afterload. And this is usually achieved by increasing heart rate and stroke volume. Hormone-mediated decrease in peripheral vascular resistance has been found. So essentially the effect of progesterone that's being produced does cause that relaxation or that decrease in peripheral vascular resistance, which you think could potentially lead to a decrease in blood pressure because of that decrease in peripheral vascular resistance. But studies have shown, there's a study by Doherty et al., which showed that mean arterial pressure is usually well maintained in these animals. So although you have that effect of progesterone, and progesterone affects many systems in these pregnant animals, but it has been shown once the animal is healthy, mean arterial blood pressure is usually well maintained. Now we want to also look at how that animal is positioned on the table, on the surgery table, on the gurney, etc. Just to draw a reference, in humans and women, supine position, which is laying on your back, there has been shown compression of the vena cava and aorta by a gravid uterus. So this is obviously later in pregnancy. And this has been shown to result in a significant drop in cardiac output and blood flow to the uterus. In dogs, however, there were some studies done in beagles and golden retrievers undergoing C-sections, and they found there was no difference in blood pressure when the animals were in lateral 10 or 15 degree lateral rotation or dorsal recumbency. Right? So in comparison to the humans, when these animals are on their backs, They didn't find that difference, so that effect on blood pressure and cardiac output. And we speculate that this may be due to the location or type of uterus that animals have, dogs and cats primarily, versus humans. However, in the supine position, again on their backs, hypotension may occur in giant breeds or when large numbers of oversized fetuses are present. So what are we talking about here? So if you look at the image on your right, you would say human uterus, and you can see that shape of that uterus. And if this person is laying on her back, the major organs are going to be, the major blood vessels, are going to be running around this way. So that gravid uterus, that is going to compress or potentially put pressure on those vessels. Whereas if you look on your left, you can see that shape of uterus in a dog or a cat. So those vessels are more likely to run this way. So they're usually not as compromised in dogs and cats versus humans. Having said that, if it's a large breed dog or you have many puppies in that uterus, so it's a very large uterus and it's taken up a significant space in that abdomen, you may get some compression of those major blood vessels. Okay, so some things to take into consideration, during a C-section is a dystocia in a dog or a cat. So now we'll switch to the respiratory system, and metabolic rate, nausea, and consumption increases during pregnancy. That's requiring increased in-minute ventilation. A decrease in the functional residual capacity, or FRC, occurs in women, and we speculate because it occurs in humans, it's likely to occur in dogs and cats as well, especially, again, if there's many fetuses in there, they're very large, taking up a significant amount of space in that abdomen and pushing the diaphragm cranially. So that's the key there. That diaphragm is being pushed cranially, essentially space in that thoracic cavity is going to be decreased. This decrease in FRC, or functional residual capacity, in the face of increased metabolic rate, nausea, and demand, increases the risk of hypoxemia. So just to give you a visualization, this has been taken from humans, and you can see in this chart on the left, y-axis, if you will, represents total lung capacity, so that's 4,200. And at the bottom is time, so x-axis is time. And if you compare the two, so this one you can see non-pregnant, and on this one, you're right, you see a gravid uterus. And obviously, it's really more relevant in a gravid uterus because you're going to have that pushing of the diaphragm cranially. You can see that your functional residual capacity, or FRC, goes from 1,700 in a non-pregnant animal to about 1,350 in a pregnant animal. So that FRC is decreased. And that's really because of that space that's been taken up in the abdomen and pushing cranially on the thorax. However, to compensate for that, your tidal volume increases from 450 to 600, right? Inspiratory capacity goes from 2,500 to 2,650, all right? Total lung capacity goes from 4,200 to 4,000. Now, this is human data, but it's very relevant, I believe, to animals as well, dogs and cats, just because that amount of space that's taken up in the abdomen by this gravid uterus is pretty similar to that in a human. Okay, so bear these things in mind when you're doing surgery or anesthesia on these animals that are, presenting for a dystocia, even as well as for a routine elective C-section, because in a routine elective C-section, while the fetuses may not be compromised, you still want to make sure and meet their demand for oxygen. So pre-oxygenation is key. There was a study done by McNally et al. In Florida quite a few years ago, and they found that this is in healthy non-pregnant patients, but I think it's relevant for almost every case that we do, they found that when they pre-oxygenated dogs for about 3 minutes prior to induction, if after induction these animals became apneic or were unable to breathe for whatever reason, they maintain their saturation, the oxygen saturation, for about 3 minutes. Because essentially what you're doing, you're filling that FRC, or that functional residual capacity, with 100% oxygen. So that's going to give you some time to try and secure an airway. And again, remember, in a pregnant animal, with a gravid uterus, so the end of pregnancy, that FRC will be reduced because of the reasons we previously spoke about. Now, when you're pre-oxygenating an animal, the image on your left is not recommended. Having a circuit at the animal's face without a face mask, as you can see on your right, is not going to provide much benefit to these animals. Studies have shown that there's a significant increase in the partial arterial pressure of oxygen, PaO2, when a face mask was used versus no face mask. So while the intention may be good to have that circuit in front of that animal's face, you always want to have a face mask over that patient when you're providing that oxygen for them. And that face mask should be left on there as shown in the dog for about 3 minutes. You induce that patient and you immediately take away that face mask and intubate the patient. You don't want to have any lag time between taking away that face mask and intubating the patient, because that 3 minutes that we spoke about previously, where you have, if the animal starts to decompensate, will be lost if you're kind of taking some time to get the animal intubated. Okay, so the key takeaway from this slide is use of face mask. If your patient would not allow it, that patient may not be sedate enough, and you may want to consider sedating that patient a little bit more, or at least having that face mask just at their nose, so they're still getting some benefit from that oxygen. Now we move to the GI tract, or gastrointestinal system. And in pregnancy, there usually is a delayed gastric emptying and increased gastrointestinal transit times. Increased gastrointestinal transit times means basically that the ingester of food stays in the GI system longer than it would otherwise. What's the reason for delayed gastric emptying? Well, there are a couple of reasons. The expanding uterus, so you can see this image on the right. Again, it's a human image, but that fetus in there is sort of pushing on the stomach and also compressing the GI tract. So that stomach cannot empty as well or as easily as it would have emptied otherwise. And also the effect of hormones, progesterone, etc., tends to decrease that rate. So food stays in the stomach longer, ingestion stays in the GI system longer, intestinal system longer. The stomach may not be empty at the time of surgery. So if this is an emergency case, that animal may have eaten. We're not sure. We don't know exactly when that animal was last ate. So that animal may have food in its stomach. But it also may still have food in the stomach because, as we said previously, gastric emptying is decreased. Food's going to stay in there longer. So you have to be aware when you're going to intubate this patient and you're inducing this patient, there's a risk this animal may vomit or regurgitate. There may be food in there. So you want to do a rapid sequence induction at this time to try and secure that airway as quickly as you can. So as mentioned previously, progesterone affects many systems, and elevated progesterone levels decrease the MAC. And remember, MAC is minimal alveolar concentration, and that's the percentage at which 50% of patients will not respond to noxious stimulus at sea level. So progesterone is going to decrease your MAC of the inhalant used. What does this mean? It means that if you are accustomed setting your MAC, your percentage of your isoflurane is maybe 1.5%, this pregnant animal may need 1.3% or 1.25%. So just bear in mind, even though it's a dystocia and for delivery to occur, progesterone levels must decrease, you still tend to have enough progesterone present that's going to affect your MAC. So your animal may not need as high a percentage to keep it asleep versus a non-pregnant animal. Blood-brain barrier and placental barrier. As we said previously, again, perioperative drugs will cross those barriers and will have an effect on the neonate. So the decision has to be made, do we pre-medicate these dystocia cases when they come into us? And usually in my experience, in my practice, I do not. I have never pre-medicated a dystocia dog or a cat, but again, this is going to be dependent on the status and temperament of the dam. I work at a specialty referral hospital, so most of these dystocias go to their primary vet. The ones that come to us are usually pretty sick, so there's no need for me to pre-medicate these animals. Alpha-2 adrenergic agonists, the use of them is controversial in pregnancy because of the effect. You get that increased vascular resistance, and you get 20% usually decrease in cardiac output when using alpha-2 in your patients. Take this into consideration if you think you need to use it, but it may be required. You may have a feral or fractious animal that may be difficult to manage, and you may not be able to get IV access without pre-medicating this dog. So if I have to pre-medicate an animal, I'm going to use something that I can antagonize or reverse. So alpha-2 agonists, you could antagonize that with atipamezole. So I would consider using that if I had to. If I decide I had to use an opioid on these animals, I would prefer something that I can antagonize, such as a pure mu with naloxone, for example. So as you know, a C-section is a major surgery and analgesia is required. In other cases, non-C-section cases, non-pregnant cases, we tend to use opioids as a pre-med, part of our pre-med, or even maybe at induction. And this, what this does, it actually reduces the requirement for induction agent, so you can use less of your induction agent. It also decreases your MAC. And by doing those things, it results in a greater hemodynamic stability of that patient. However, again, there's the possibility of neonatal depression if it's used in a dystocia, especially if the animals are in distress. If the puppies are in distress or if the kittens are in distress, by giving these drugs to the bitch, it's going to cross the placenta and you may get further depression of the fetuses, and your APGAR score is going to be lower. And we'll talk about that APGAR score in a minute. Infiltration of local anesthetics prior to incision is beneficial. We'll talk about this in a second, but just remember, in most cases for the dystocias, these animals have no analgesics on board until puppies or kittens are out. So by doing a lidocaine block at the incision site, so a line block, you're going to blunt and block that nociceptive stimulation these animals will receive during surgery. Question comes up pretty often: can I give a non-steroidal anti-inflammatory agent to a dog post C-section? It's not recommended to give it prior to surgery or during pregnancy. Can I give it post C-section? There's one study that I've seen, it's a European study, where they've used a drug called cimicoxib, and they found that giving one dose of cimicoxib orally post-surgery once the animal was awake had no negative effects on nursing puppies or on the bitch. So a lot of people will give one dosage of this drug post-surgery, but again, it's going to be clinician, it's going to be based on your assessment and your judgment. Do I think it's safe to use this drug in this animal post-surgery? So now, as we get a little bit closer to talking about actual drugs, we want to bear this in mind. And for every patient that comes to anesthesia, you want to look at the ASA status, American Society of Anesthesiologists classification system. And your grading system is from 1 to 5, so 1 being a normal, healthy patient that comes in maybe for a spay or a castration, to 5, a moribund patient is not expected to survive without surgery. Okay, so every one of your patients should have the ASA status classification before you do anything to them, because that's going to help you decide how stable your patient is, what drugs are appropriate, etc., to move forward with this animal. Now, I know this is a really busy slide and there's a lot of information on here. My key takeaway for this slide is to look at what's on the left column of the slide. Don't worry about reading the things on your right. Before you start any procedure, you want to make sure that you've got everything set up and ready to go. Make sure your CO2 absorbent is ready. Make sure you have an oxygen supply and you have enough oxygen that's going to supply that animal throughout the procedure. Make sure you have multiple sizes of endotracheal tubes. We always tell our students to have at least 3 sizes. Have the size, one size that you think is appropriate for that animal, and then have a size above and a size below that. Because when you go to intubate that patient, you may realize that your tube is either too large or too small, and you don't want to have to run back and forth to get a tube, because the animal may not be breathing. So you want to have at least 3 sizes at hand. You want to have a face mask so we could pre-oxygenate these patients, as we mentioned previously. You want to have your breathing system ready, so whether it's a rebreathing or a non-rebreathing system you're using. Make sure you have inhalant, isoflurane, sevoflurane, desflurane, whichever you're using. Waste scavenging equipment is connected up, and you have electronic monitoring equipment. Everything must be ready to go before the animal receives any drugs. So for cesarean section, what's recommended? The induction agents that are recommended are alfaxolone or propofol. There was a study done which compared alfaxolone and propofol. In the US, alfaxolone is rather expensive. I know it's not available in many places. So this study compared alfaxolone and propofol, and they found that 1 hour after birth, the APGAR score of the puppies was higher in the alfaxolone group versus the propofol group. Now remember, you're aiming for a very high APGAR score. 24 hours out, there was no significant difference between the 2 groups, the alfaxolone and propofol group. So we recommend, if you're in a practice where you have propofol or ketamine diazepam or maybe etominate or something to induce your patients, if you don't have alfaxolone, I would recommend propofol for these cases. I would not recommend ketamine diazepam, ketamine midazolam for a C-section induction agent. Previously, we used to give top-ups of alfaxolone or top-ups of propofol before, until the puppies or kittens were delivered, and then we turned on inhalant. The newer recommendation now is to induce with alfaxolone or propofol, and then turn on your inhalant. And these studies found that the bitch and puppies did better in the alfaxolone plus inhalant group. So no longer really is a recommendation to just keep topping up with propofol or alfaxolone, but induce with propofol or alfaxolone, and then maintain on inhalant. So for a sample protocol, let's just go really quickly through a step-by-step plan for these dogs. So this dystocia case comes to your door. You want to place an IV catheter when this animal presents to you. And obviously, you're going to take blood work, get a baseline, assess your animal, do an ultrasound. You know, that whole checklist we went through initially, you're going to go through that entire checklist, deem that your patient needs to move forward to have surgery. At this point, you're going to clip and prep this animal as much as possible without any drugs on board. Because if there are drugs on board, as we said a few times, these drugs will cross the placenta and can compromise the health of the puppies or kittens in utero. You want to ensure all equipment and drugs are ready. So check your anesthesia machine, make sure there's no leaks. You've got everything we need. You've got your tubes, you've got a laryngoscope. And a laryngoscope must be used to intubate every single patient that you could visually intubate. The laryngoscope doesn't only provide the ability to help you intubate your patient. When you're using a laryngoscope, when you intubate an animal, that's the only time that you're gonna have to assess your animal's oral cavity. You may find masses, you may find foreign bodies, you may find problem with laryngeal function. So laryngoscope, in my mind, and for any patient that I have in the hospital here, must be used to intubate every single patient that you could visually intubate. So horses obviously will be an exception to that rule. Ties should be present, and you must have monitoring equipment ready, and you must preoxygenate this animal. Recommendation for inductions, we said either propofol or alfaxolone, and remember these drugs are given to effect. What I would recommend is to have extra drug that you use to induce your patient, because again, the patient is not going to have any analgesics on board, so that patient may be a bit reactive during surgery. You may need to top up that patient, although they are on inhalant. So rapid sequence induction, intubate, check for a leak, secure that airway. Turn oxygen on an inhalant and perform a line block using lidocaine. The reason I say lidocaine versus bupivacaine is because bupivacaine takes a little bit longer to act than lidocaine. And you want, as soon as that line block is performed, you want to cut that animal and get into that abdomen to get those puppies or kittens out, especially if it's a dystocia and they're in distress. If it's a planned C-section or elective C-section and you have more time, and bupivacaine may be appropriate in that instance. In this case, for dystocia, you don't have that time, so you want to get in there quickly, so lidocaine will be recommended. And then administration of opioids, pure MUs are recommended, but if you do not have a pure MU, then you could use something like maybe buprenorphine. Here, I just want to show an example of that line block that's being performed. So the animal is already clipped and prepped, and then you're going to do that line block at the incision site. We usually have our surgeons do the line block. So you can see this picture, the animal's sterile, prepped, and ready for surgery. The surgeon gets the lidocaine, does their line block, and then they're ready to cut. Our surgeons, when we're going to do these cases, once we induce these animals, our surgeons are already scrubbing and waiting for that animal to get on the table. So as soon as that animal is on the table, they're able to just get in there and cut and get started. So once the procedure is completed, last kitten or last puppy is out, that's the point at which you can consider giving your opioid. I also like to perform an epidural in these cases, but I do the epidural just prior to recovery. Surgery is completed, abdomen is closed, puppies, kittens are out, then I perform the epidural. I do not do the beginning because the epidural takes a little bit of time, and that if it's a dystocia and puppies or kittens in distress, you may not have that time available to you. So I usually recommend to do an epidural at the end of surgery, just before the animal wakes up. And I would usually use morphine, preservative-free. Morphine, if you do not have preservative-free morphine, then you can consider using buprenorphine once it's been deemed appropriate for an epidural administration. And here you can see an image on your right, just basically landmarks for doing that epidural. The reason I do not use a local anesthetic in these cases is because local anesthetic is going to block motor function. When this animal wakes up, and as soon as I do the epidural is completed, I'm going to wake up that dog because she may have puppies, kittens to go take care of. If you use a local anesthetic in there, that animal may not be able to walk for a while. So therefore, discharge will be delayed. And remember, if you have puppies, newborn puppies in the hospital, there's nosocomial infection, etc. It's a strange environment. The bitch or queen may not want to nurse, etc. She can't stand and walk around, so you have to. It's going to put more load on your staff to really help take care of those puppies and kittens after the procedure is completed. So I use that morphine to kind of provide sensory blockade versus a local anesthetic, which will provide motor blockade as well. Non-steroidal, we previously discussed cimicoxib, may be an option, obviously in Europe, may not be an option in all countries. Some clinicians will give one dosage of a non-steroidal other than cimicoxib post-anesthesia, but again, case dependent. And you may need to antagonize drugs that were administered to the bitch in the neonate. So if an opioid was given or a benzodiazepine was given, then if the puppies or kittens are compromised, you may need to consider antagonizing those drugs in them. So that was our brief discussion on dystocias. Now we're going to move into talking about management of the neonate. And here we're going to talk about the APGAR score. So the APGAR score was developed by Dr. Virginia APGAR in 1952. She was a human anesthesiologist, and she created this scoring system. It stands in humans, it stands for activity, pulse, grimace, appearance, and respiration. And as you can see in the chart on the top left of the screen, the maximum amount of points a baby can receive is 10. So you want to aim for that high score. There's a modified APGAR score created for animals, and you can see at the bottom right of your screen. So the higher score, the higher the better viability of that animal. So that's what you want to aim for. So all the drugs we use in these cases are really aimed towards trying to maintain that as high APGAR score as we possibly can. So management of these neonates, what do we do? Well, you want to have a neonate resuscitation kit available. So you want to have a bulb syringe to aspirate all of that liquid in their mouth. You want to make sure you keep them dry, keep them warm, right? And then the APGAR score is key. As I said, the high APGAR score is better. If there's a low APGAR score, then we need to address that problem. In that kit, you'll want to have sterile gloves. You'll want to have clamps because you want to clamp off that umbilicus once the puppy or kitten is handed off to you. You want to have sterile towels, right? Because these puppies or kittens should not be handled with bare hands. You should have gloves on. Then oxygen supplementation. Flow-by versus intubation. If the animal is not breathing, then flow-by oxygen is useless. You want to consider intubating these animals if you can. Medications such as epinephrine can help. Dopram is no longer considered useful in neonates. It's been found primarily in humans that babies don't respond to it. They don't have receptors for it. So it's not very beneficial, and it's no longer really used in emergency settings for human babies. And then you also want to have antagonists. As I said previously, if you're going to give any drugs to that bitch with puppies or kittens still in uterus, you want to make sure you have antagonists for those drugs. Otherwise, you may want to hold off on them if there's a distortion and the puppies or kittens are in distress, because we can't take it away, if we need to do that. So what antagonists are present? Well, naloxone is going to antagonize your opioids. Ideally, it's going to antagonize your pure mu's better, but it will have some effect on antagonizing others as well. And a puppy, you want to administer it either intravenously. Duration of action is about 45 to 90 minutes. Flumazenil is going to antagonize your benzodiazepines, so drugs such as midazolam, diazepam. Natipamezole is going to antagonize your alpha-2s. Again, these drugs should really not be administered to the bitch or queen prior to delivery of the puppies or kittens. Acupuncture also has a role to play in these neonates. Maybe 26 antihistamines tigers, and it's been I would say I have about maybe 90% response rate by using this point. So GV26, government vessel 26, has been useful in my experience. If your puppy or kitten, or in this case piglet, cannot breathe, I recommend intubating them if you can. This was a case that I had, and this piglet was born, wasn't able to breathe, so we used an IV catheter. We were using a large animal, intubated it, was able to provide oxygen to this animal, and actually did pretty well. This animal got epinephrine and intubated and then provide oxygen, did pretty well. So something to think of. If you can't get your animal to breathe, you've stimulated it, you've dried it, you're constantly doing everything you can, and it's still not breathing, but you have a pulse, you have a heartbeat, then try and consider intubation and see if that will help you with your puppies or kittens. Okay, so that was our brief chat on neonate. Now I want to touch a little bit on Pyometra. So change in sort of a change in topic, still dealing with the reproductive system, but Pyometras they're closed versus open systems. Closed Pyometra animals are usually a lot. Their likelihood of not doing well is a lot higher with a closed versus an open Pyometra. With open Pyometra, you will have some drainage, so the animals are usually not always as sick as a closed animal, a closed Pyometra. Again, you need to know their ASA status. Is it a 3? Is it a 4? What is the ASA status? And you want to stabilize these patients before these animals come to anesthesia. You do not want to rush these animals into surgery. What do I mean by stabilize? Well, you want to get some blood work on them, CBC, complete blood count, biochemistry. Are they hypovolemic? You need to stabilize these patients, provide fluid therapy to these patients. There may be electrolyte imbalances that you want to check and get them stable, because if a patient goes into surgery or goes under anesthesia with a PCV or hematocrit of 55, 60, that animal's probably not going to do well, right? Oxygen supply to organs, etc. will be compromised. So make sure these patients are stable as well as they possibly can before they get to surgery. You want to check blood pressure. Is this patient hypotensive? What do I do to help correct this hypotension before I take this animal to anesthesia? Okay, so stabilization is key to these animals. These animals should not sit overnight if they do have a Pyometra. Pyometra is an emergency case and needs to be addressed quickly. So stabilization may require a couple hours, and then this animal has to go to surgery. So what are anesthetic considerations or drugs to consider using in these cases? So opioids and pure mu opioids will be best suited to this case. If pure mu opioids are not available, then you're going to have to use what is available to you. So butorphanol, not ideal. Buprenorphine may be better. Acepromazine, I have here no acepromazine for these animals, because a lot of times these animals are hypotensive. They have endotoxins being present, so all your cytokines, so interleukin 1, 6, 8, TNF alpha, all of these things lead to vasodilation, and endotoxins lead to vasodilation, hypotension. Acepromazine is going to cause vasodilation. If you give acepromazine to a patient that's already hypotensive and has all these cytokines, etc. present that are causing a decrease in blood pressure and vasodilation, we're going to have to battle a lot harder to try and maintain a normal blood pressure in these animals. There's no antagonists for acepromazine, so you're stuck with its effects for about 6 to 8 hours. As we said previously, when we go through our checklist, if this animal is an animal that has a MDR1 or ABCB1 gene defect, then the duration of action of acepromazine is going to be even longer than 6 to 8 hours. And this animal's ASA status can be increased, right? So these animals will be further compromised. So I would avoid acepromazine in these animals. Dexmedetomidine will be a consideration. If the animal is still it's sick, but still pretty aggressive, and you can't get access to get an IV catheter in, then an alpha-2 may be a consideration. So it's going to be down to clinician judgment at that point. What drugs can we use for induction of these cases? Ketamine is a sympathomimetic, right? It's an NMD antagonist, so N-methyl-D-aspartate antagonist. Will provide some analgesia as well. So ketamine and diazepam or midazolam will be an option. Propofol you can get a transient hypotension, so you have to be careful using propofol in these cases if they're already hypotensive, but it can work. You can also combine propofol and ketamine, and I would usually do 3 milligrams per kilogram of propofol plus 3 milligrams per kilogram of ketamine, combine in the same syringe and administer slowly to effect. Propofol and midazolam, I would usually do 1 milligram per kilogram of propofol first, and then maybe 0.2 milligrams per kilogram of midazolam or diazepam. Assess your patient, can I intubate off of that? If I can, I will. If not, I would administer a little bit more propofol to effect. So why do I have these co-induction agents with propofol? Because ketamine and midazolam or diazepam significantly reduce how much propofol you need to intubate these animals. Alfaxolone will have the same effect on decreasing how much alfaxolone you need to intubate these animals. So by decreasing how much propofol you need, you decrease the side effects that come with propofol. Midazolam, diazepam have minimal, if any, effect on the cardiovascular system. So if these animals are compromised in that manner, then it'll be appropriate to use those drugs. But with ketamine, if the animal has heart disease, you're going to want to avoid ketamine. Okay, so this is why, again, that checklist is key. So maintenance. So I have oxygen plus or minus inhalant. What does that mean? If these patients are really sick, if they're maybe ASA4, maybe ASA5, a lot of times these patients don't need an inhalant to keep them asleep. They're pure mu, and perhaps a little bit of top-ups with your induction agents are all these patients need. Because remember, inhalants contribute to vasodilation as well. The higher you turn up your vaporizer, the more likely you are to vasodilate these animals, and the more likely you are to see a further decrease in blood pressure. So it's going to be a challenge to maintain a normal blood pressure with an animal. And what's a normal blood pressure? It's considered mean over 60 millimeters of mercury. So that's my goal, to maintain a mean blood pressure of over 60 millimeters of mercury in a patient. If I'm using a Doppler, 90 is my minimum blood pressure in a Doppler for a dog, and 60 is my minimum blood pressure for Doppler in a cat. If your patients are doing well, we usually start them at a low percentage of inhalant, but if they're not doing well, we usually would turn off their inhalant. Fluid therapy, again, your animals should have been stabilized before anesthesia, but we generally use lactate ring solution, or LRS, for these patients. Colloids are contraindicated in any patient that's septic or potentially septic. In human, there's been multiple studies done in humans where they found that heterostoch, for example, can lead to renal disease or renal failure. So it's not recommended. I would not use heterostoch in a patient that is septic or potentially septic. Having said that, if I've exhausted every other resource that I have and I have nothing else available to me, and heterostoch is an option, I would consider using it. But I would have had to exhaust every other resource I had available before I would go to heterostoch. And then intraoperative antibiotics as necessary. The other thing to consider in these cases is doing a ketamine CRI, assuming the animal has no heart disease. Ketamine CRIs at 20 micrograms per kilogram per minute has been shown to provide analgesia to your patients. And I think it also kind of helps keep these animals asleep if you do not want to use inhalant, because as we mentioned previously, turning up your inhalant will lead to vasodilation and further drop in blood pressure. So how do we support these patients if these patients are hypotensive under anesthesia? What we do, we still do it currently. What's been previously done in human world, we would use a lot of crystalloids. So they'll get a lot of fluids, a lot of LRS, for example. Studies have been shown in studies that by providing a lot of crystalloids to patients, you dilute many factors that these patients need for normal function. So clotting factors, etc., diluted, and these animals don't do very well after surgery if you use excessive amount of crystalloids. In human world, they're moving more towards blood products, so whole blood, packed cell volume, etc., to supplement and to provide fluids to humans to help maintain blood pressure, blood volume in surgery. It's a little more difficult for us in veterinary world to do that at the moment because blood products are not readily available. They're usually very expensive. So the only places that tend to have these things are, university hospitals or maybe some specialty practices. So currently, we don't really have that option. Many places to have blood products available for our dogs and cats. But it's the way that the human world is heading to help maintain blood pressure and volume in humans. What we use are drugs such as norepinephrine, dobutamine, and dopamine. These drugs work a little bit differently. Each one works a little bit differently. For example, if I have a somewhat healthy patient that's under anesthesia and it's not doing very well, I'm going to use dobutamine because dobutamine has mostly effect on beta-1 receptors. And that's really those receptors are found more in the heart. So by giving dobutamine to a patient, you're going to help improve contractility and maybe even increase heart rate a little bit. Because the anesthetic drugs we use also suppress the cardiac system to a certain extent. So your heart rate or maybe even contractility of the heart is decreased. So by administering dobutamine to a patient as a CRI, a constant rate infusion, usually I would start at 5 micrograms per kilogram per minute for these patients. So dobutamine kind of helps improve contractility and heart rate to a certain extent in these patients. Dopamine works on many receptors. So it works on dopaminergic receptors at a low rate. Then as you increase your rate of administration, it tends to act more on beta receptors. And then you go further up, it acts more on alpha receptors. So dopamine is a good drug as well to use in those situations because it's going to help increase contractility. And as you go higher with your dopamine, you will have some effect on the vascular resistance by increasing resistance to a certain extent. Norepinephrine is a drug of choice for a septic patient or a patient that's significantly hypotensive because norepinephrine is going to also give you some vasoconstriction. So for this Pyometra case, for example, if I have a case that's really hypotensive, and I think that hypotension is due to those cytokines we just mentioned, to those endotoxins that we mentioned, then given a drug like dobutamine or maybe dopamine is not going to be very effective because if you think of it, if your patient is very hypotensive and it's because of vasodilation of your vessels, your preload or the blood that's coming back to your heart is decreased, is compromised. So if I give dobutamine to this animal and I make its heart beat harder, right, increase contractility, it doesn't have that volume to push out because the preload is decreased. So your stroke volume is not going to be improved, your cardiac output is not going to be improved, and your blood pressure is not going to be improved. So for septic cases, so very, very hypotensive cases, I would start with norepinephrine. And what's norepinephrine going to do? It's going to give me some vasoconstriction. By vasoconstricting, it's going to help improve my preload. Once the preload increases, so you have more blood returning to the heart, then if I'm still struggling with blood pressure, then I will add something like dobutamine or maybe even vasopressin, right? Because that dobutamine was once our preload is improved or improving, if I increase contractility, I improve or increase the contractility of the heart with something like dobutamine, it's going to help improve my stroke volume. If my stroke volume improves, then my cardiac output is going to improve. If my cardiac output is going to improve, then my blood pressure is going to improve. Norepinephrine works very well with vasopressin. Vasopressin works at multiple places. It works at the vessel level and also works at the renal level. So vasopressin is also a good drug to use to add on to norepinephrine. It's recommended to start with norepinephrine and then add vasopressin. Problem with vasopressin, at least here in the US, is that it's very difficult to get. It's also very expensive. So we tend to do more norepinephrine first, and then dopamine on top of that to get that, that increase in blood pressure. So that was Pyometras. So now we're going to talk a little bit more about brain lesions or patients with head trauma or brain tumors. And the equation that I want you to remember is CPP is equal to MAP minus ICP. So cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. What is CPP? CPP is essentially net pressure gradient that is responsible for supplying cerebral tissues with oxygen. So that's the main goal here. You want to maintain normal cerebral perfusion pressure to provide oxygen and nutrients to the brain. If this perfusion gets compromised, then problems can result. Significant problems can result as of that compromise. So before we go any further, we need to talk about the Monro-Kelly doctrine. Monro-Kelly doctrine essentially says that within the cranium, within the skull, you've got three types of tissue. You've got brain tissue, you've got blood, and you have cerebral spinal fluid or CSF. Essentially what's happening here is that what I'm saying is that if one of those tissues increases, something else must decrease to maintain a normal intracranial pressure. So if there's a brain lesion and there's a brain tumor and that tumor is increasing in size, therefore your brain tumor tissue is increasing, so that blood or CSF that's returned to the brain has to decrease, otherwise intracranial pressure is going to increase. So it's really key to know what's happening with your patient, and this is where anesthesia and drugs could have a profound effect on this patient. So what precautions do we take in these cases? We may have a patient that presents to you, this patient has a history of seizures. Does this patient have a brain tumor? Well, I don't know that until we do maybe a CT or ideally an MRI, but that requires doing general anesthesia on this animal. And if I use inappropriate drugs or we don't do anesthesia appropriately, we can cause a problem such as the Cushing's reflex, right? We could cause brainstem herniation. Brainstem herniation leads to this Cushing's reflex or this Cushing's triad. And essentially what you see with the Cushing's triad is a bradycardia, hypertension, and an aberrant respiratory pattern. Why do we see those things? Because most of those centers, those respiratory centers, etc., are located in the brainstem. So if the animal starts to herniate its brain, you're going to start seeing that aberrant respiratory pattern. Okay. The other factors which would contribute to that bradycardia and hypertension, essentially what happens if the brain tissue is compromised and CO2 levels start to increase. The body's going to try and increase heart rate to get more blood flow to the brain. Increase in heart rate causes an increase in blood pressure. Baroreceptors sense this increase in blood pressure, and body is trying to maintain homeostasis, right? It's trying to maintain a normal blood pressure. So if your baroreceptors sense this increase in blood pressure, you're going to get a vagal response, which then leads to a decrease in heart rate. So that's your bradycardia, your hypertension, and then usually end stage, so stage 3, is when that brainstem starts to herniate, and you get compression of that brainstem, and then you can see that this aberrant respiratory pattern. So all these things need to be taken into consideration when we're assessing this patient, evaluating this patient, and deciding, okay, what drugs do we need to use for this patient? Why are we considering this gag reflex? Like, why do I care if this patient has a gag during intubation? How do I position this patient on a gurney or table? And how is end-tidal CO2 significant? Okay, and we're going to talk about all these areas as we proceed, because these are really key areas. And remember, PaCO2, so partial arterial pressure of carbon dioxide, is a lot more important than end-tidal CO2. We don't always have the ability to monitor PaCO2 in our patients. Our patients get an arterial line. Every patient is going to MRI, gets an arterial catheter placed. So we can assess PaCO2, but that's not always feasible or possible. So we tend to use our end-tidal CO2 as a gauge to give us an idea of what our PaCO2 is. And we'll talk a little bit more about that as we proceed. So let's focus on drug selection for a minute. So you have a patient who comes in with a history of seizures. Previous studies told us do not use acepromazine on these patients because acepromazine causes a decrease in seizure threshold, and these patients are more likely to have seizures. Newer studies are showing, or have shown, that acepromazine perhaps increases the seizure threshold and does not cause patients to have more seizures. For me, it's a little bit of a gray area. I do think that that's correct. However, I still tend to avoid acepromazine in patients having seizures unless I think acepromazine will really benefit that animal. If I think acepromazine is going to benefit that animal, then I will consider using acepromazine, and I would probably use a low dosage of it. What's a low dosage for me? A low dosage of acepromazine for me is 0.01 to 0.02 milligrams per kilogram. So would I use acepromazine in a seizure patient or patient with brain tumor? Maybe, but I don't use it that often. Very, very, very unlikely. Very rarely have I ever used acepromazine in a seizure patient, but you can carefully. Alpha-2 adrenergic agonists, I avoid in any sort of brain head trauma case because alpha-2 adrenergic agonists are normally effective on alpha-2, so let's say dexmedetomidine, for example, you will get a bradycardia and a hypertension because alpha-2s cause that vasoconstriction. That vasoconstriction causes increase in blood pressure, and then you get a reflex bradycardia as a result of it. And you also get a central effect of that dexmedetomidine in the brain, which can also contribute to bradycardia. As we just said, with that Cushing's reflex or that Cushing's triad, you see a bradycardia and a hypertension. So if I have an alpha-2 on board in these animals, and I see a bradycardia and hypertension, I'm not sure what's contributing to that. Is it just the alpha-2, or is this animal having a Cushing's reflex? I don't know. So I avoid alpha-2s in these cases, as well as by vasoconstricting these animals, I may also potentially decrease perfusion to the brain. So I try to avoid that because I think the risk of using alpha-2 is higher than the benefit in these cases. So I avoid alpha-2s in these cases. Opioids, I will use opioids in brain cases, but my preference is butorphanol. Why do I want to use butorphanol? Because other opioids, such as morphine or hydromorphone, a side effect of those drugs is vomiting. And that's why you have the antiemetics. So a drug such as Cesarean or meropetant is really, I use Cesarean or meropetant in every one of these cases because the act of vomiting causes an increase in intracranial pressure. It also causes an increase in intraocular pressure. So if you have a patient with a desmetocele or a significant ulcer of the eye, that patient vomits, you could rupture that desmetocele because you may have been taking that animal to surgery to do a conjunctival flap or graft. If that desmetocele, that ulcer ruptures, then that may have to convert to enucleation. So I would avoid drugs that cause vomiting in animals, such as morphine or hydromorphone, because of the risk of increase in intracranial pressure in this case, or intraocular pressure in cases where the eye is compromised. So I also, as I said, will also use an antiemetic, such as Cesarean or meropetant in these cases, because even though we're not using any drug, we may not be using any drug that causes animal to vomit, I still want to prevent the animal from vomiting. So Cesarean or meropetant is a very good drug to use. Acepromazine also has antiemetic properties, but again, does the benefit outweigh the risk? So it's something you have to take into consideration as a clinician. Do I think acepromazine is appropriate for this case, yes or no? Lidocaine, the reason I have lidocaine there, because I would use lidocaine as a part of my intubation agents, for intubation. I would use 2 milligrams per kilogram of lidocaine because it has been shown if you give lidocaine systemically, lidocaine tends to blunt that gag reflex. And if you remember from a previous slide, we spoke about gag reflex during intubation. So I give lidocaine to blunt that gag reflex because that gag reflex can cause an increase in intracranial and intraocular pressure. If the animal has a brain tumor, and we don't know exactly what's happening in that brain until we do MRI, if that animal gags, we could risk brain herniation. So we tend to use lidocaine to blunt that gag reflex to hopefully not cause any additional problems. I would also use propofol for induction of these cases. And I usually like to combine propofol with the benzodiazepine for a brain lesion case, especially if that patient has a history of seizures. Midazolam, diazepam are drugs we use to treat seizures in patients. So I kind of preemptively have that drug on board because obviously animal is not going to have a seizure under anesthesia, but it could have a seizure in recovery. So I usually will combine propofol with midazolam or propofol with diazepam, because as we said previously, your benzodiazepine is going to decrease the amount of induction agent that you need, propofol or alfaxolone. Plus, having that benzodiazepine on board, I think, gives me a little bit of a buffer, gives me that safety, thinking that the benzo is going to help reduce likelihood of seizures if I have it on board. So I would have a dose of benzo calculated. So usually I calculate 0.5 milligrams per kilogram of midazolam or diazepam and have that in my protocol sheet. So if the animal does recover and have a seizure, I have my volume calculated already, so I know exactly how much drug to give to administer to that animal. But for induction, I do, as I said previously, propofol 1 milligram per kilogram, followed by maybe 0.2 to 0.25 milligrams per kilogram of midazolam or diazepam, and then more propofol if needed. So that's the kind of combination I like to have for my induction. Then we said patient positioning is also something we need to take into consideration. So here you can see reverse Trendelenburg and Trendelenburg. Reverse Trendelenburg is the head elevated and the feet down, versus Trendelenburg is feet elevated and head down. So as we previously said, going back to the Monroe-Kelly doctrine, if one thing out of those three tissues, so brain tissue, blood, or CSF, if one of those increases, then we need to decrease the others to try and maintain normal ICP, or at least try not to increase ICP. So once these patients come to us, these patients are placed in this position, in a reverse Trendelenburg position. Why? Because if the head is elevated, the amount of blood flow is not going to be as high versus if the patient is flat on the table. Also, it's going to kind of help drain CSF out to the brain to a certain amount, right? If the patient's lateral is flat on the table, CSF, blood flow potentially increase to the brain, can contribute to increased intracranial pressure. So by having the head elevated in a reverse Trendelenburg position, you're less likely to have that CSF or blood sort of accumulate in there. So it's more likely to drain out and doesn't flow in as quickly into the brain. So that's going to help maintain our intracranial pressure. Trendelenburg position is not recommended for any patient with head trauma, brain lesions, brain tumors, etc. So always have a patient's head elevated. Picture is a little more relevant to us in veterinary medicine, is as shown here. And you can see there's a towel wrapped and placed directly under this dog's neck versus a solid surface the animal is on with that towel underneath that surface. If the towel is placed underneath that animal's neck directly, as in image A, that head or nose is likely to fall down, and you're going to get compression of the cervical region. So your jugular veins, etc., can be compromised, and that can also contribute to increased intracranial pressure. So I would have that towel underneath that plank to maintain that reverse Trendelenburg position and not compromise blood flow out from those jugular carotid vessels. Okay, so position B is what you want is how you want to have your patient positioned on your gurney or your table to achieve that same goal as we showed here for reverse Trendelenburg position. Okay, so we're aiming for reverse Trendelenburg, and we're aiming to have image B and how the animals should be placed on the table or gurney. And you want to really aim for a 30-degree angle. Okay. So now we're going to change to the respiratory system, and our focus here is on end-tidal CO2. But remember, end-tidal CO2 in a patient with a healthy thoracic cavity, healthy lungs, healthy pleural, etc., your end-tidal CO2 varies from your PaCO2 by about 0 to 5 millimeters of mercury. So what does this mean? So it means your PaCO2 is usually higher than your end-tidal CO2 by 0 to 5 millimeters of mercury. So we look at our end-tidal CO2 all the time in these cases because we don't always have access to arterial blood samples. And you know, if your patient's end-tidal CO2 is 30, it could be as high as about 35 millimeters of mercury. So in a healthy patient under general anesthesia, we aim for end-tidal CO2 of about 30 to 55 millimeters of mercury. 55 is still considered acceptable for ASA1, potentially ASA2 patients. Okay, it's really called permissive hypercapnia, and there's some benefits to having CO2 a little bit higher in these patients in terms of helping maintain cardiac function, etc. So if I know if my end-tidal CO2 is 30 to 55, I know my PA CO2 is about 35 to 60. Okay, so that's 0 to 5 millimeters of mercury difference. That's what you're kind of thinking about. And a head trauma patient, or a patient with a same scenario, right? Head trauma patient, there's a brain tumor, there's a lesion, etc. My end-tidal CO2 then becomes very significant. And you really need to have CO2 monitoring in these patients because you want to maintain an end-tidal CO2 of about 30 to 35 millimeters of mercury. The goal for your PA CO2 should be about 35 to 40 millimeters of mercury. And a lot of times, a ventilator is going to be really helpful. So mechanical ventilator is going to be really helpful to maintain or to ensure that end-tidal CO2 stays between 30 to 35. Some people may ask, well, why not? Why can I not just ventilate these patients and keep my end-tidal CO2 very low? Because end-tidal CO2, when end-tidal CO2 gets very low, usually below 20 millimeters of mercury, you tend to get vasoconstriction. If you get vasoconstriction, we're going to compromise blood flow to the brain, which is not ideal. You want to maintain an ideal blood flow to the brain. You don't want to decrease or compromise blood flow. So less than 20 millimeters of mercury of end-tidal CO2 is going to compromise blood flow to your brain. You're going to get vasoconstriction. The reason why we don't want to go over 40 millimeters of mercury on our PA CO2 is because if your CO2 gets too high, so the animal becomes hypercapnic, then you get vasodilation. Vasodilation is going to contribute to increased blood flow to the brain, which again, with the Monroe-Kelly doctrine, if we have more CO2 in there, we have more blood flow. So you have more blood in the skull and cranium, then that's going to potentially contribute to increased intracranial pressure and perhaps even brain herniation. So this is why it's so key to maintain a PA CO2 of 35 to 40 millimeters of mercury. But again, if you only have end-tidal CO2, your goal should be 30 to 35 millimeters of mercury throughout the entire anesthetic period. So even if you're traveling with your patient from one location to another, you want to make sure that your patient's CO2 end-tidal CO2 stays at 30 to 35 millimeters of mercury. So for a brain lesion patient, again, that checklist is key. Assess your patient, you place an intravenous cath in your patient, and you want to get blood work on this animal. See if there's any abnormalities, anything you need to correct on that patient's blood work. Stabilize your patient as best as you can. So if your patient is having seizures, you may want to treat those seizures initially. If there's any abnormalities on your blood work, you may want to correct that as best as you can. Pretty often, blood work is not really that significant. Once you've done all of that, then you may want to assess your patient further. Once your patient is a bit more assessed, is a bit more stabilized, then you may need to do radiographs. Maybe you're looking for a lesion, you may be looking for something in the chest, maybe there's a tumor, you want to do a check to make sure there's no thoracic lesions, because some owners would want, if there's any lesions in the chest, they may not want to proceed. So you want to get some baseline information first before you go to more further diagnostics. So what anesthesia protocol would I use for a patient with a potential brain tumor, brain lesion, etc.? So again, we would pre-oxygenate our patient. I put this image here just to remind you that that face mask over the patient's nose is key. Do not use a circuit just have in front of your animal's face. It's not going to help provide appropriate PaO2. Administer butorphanol. Butorphanol, why butorphanol? Well, butorphanol, yes, does provide analgesia. Butorphanol is a mu antagonist and it's a kappa agonist. It does not cause vomiting. It also provides really good sedation. And in these cases, usually that's all they need for sedation. Sometimes, as I said, I will administer some acepromazine, but only if really indicated and if I really think the benefit outweighs the risks. Induction, we will give lidocaine. First, I give 2 milligrams per kilogram intravenously of lidocaine, and I follow that with propofol plus a benzodiazepine, either midazolam or diazepam. Maintenance with either isoflurane or sevoflurane and oxygen, and then fluid therapy, the lactated ringers. In dogs, the 2013 AHA, American Association of Hospital Associations, recommends you start with dogs at 5 mils per kg per hour for fluids and cats at 3 mils per kg per hour. Okay, so I will start with that rate, and I would change that rate as needed. So in summary, for brain lesion patients, you want to maintain your patient in reverse Trendelenburg positions. Again, that's head up, butt down, so head up elevated position. You want to maintain your end-tidal CO2 between 30 to 35 millimeters of mercury, knowing that your PA CO2 is going to be about 35 to 40 millimeters of mercury in a patient with a healthy chest. If there's problems with thoracic cavity, problems with lungs, etc., then you would really want to try and get an arterial gas on these patients and know what the patient's PA CO2 is. Or perhaps you want to consider having that end-tidal CO2 a little bit lower, knowing that your PA CO2 is going to be higher. For example, if you're doing surgery in a patient, thoracic surgery in a patient, not head brain lesion associated, when you open up that thoracic cavity, the difference between your end-tidal CO2 and your PA CO2 becomes significantly higher. You could have a difference from about 30 to 40 millimeters of mercury difference between your end-tidal CO2 and your PA CO2. So if your patient has any sort of respiratory disease, bear in mind that your PA CO2 may be much higher than your end-tidal CO2. You want to monitor for Cushing's reflex. And if you do see signs of a Cushing's reflex occurring, there's a couple of ways you can do this. You could administer hypertonic saline or mannitol. Right, mannitol is a diuretic. It helps to decrease the fluid within the brain. It also helps decrease CSF production to a certain extent. Mannitol has been the method recommended for treatment of increased intracranial pressure previously, but newer studies have shown that hypertonic saline may actually be more beneficial to these patients. Mannitol should be administered slowly over about 20 to 30 minutes, and it should not be used for an extensive period of time. You also want to maintain a normal blood pressure in these patients. Okay, so that's a summary on patients with brain lesions or head trauma, brain tumors. So now we're going to talk, our last topic for the day is the trauma patient, so automobile accident patient. So a patient comes to your practice. You always want to assess your patient first and stabilize that patient before diagnostics are done. A fractured bone is usually not going to kill a patient, but rushing a patient to X-ray, for example, that hasn't been stabilized, that has a pneumothorax, that has not been detected, could kill that patient. So assess your patient initially, place an intravenous catheter, get some blood work for diagnostics, initial blood work diagnostics. Once your patient has been deemed to be stable, so you've done your full checklist again, you've auscultated the chest, you've checked for pulses, you've got your heart rate, respiratory rate, temperature. A lot of times, if this has been a recent incident, these patients are going to be in shock. So these patients are going to be tachycardic and perhaps hypotensive. So you want to address that first before doing diagnostics such as radiographs, ultrasound, etc. You can do a fast scan with your ultrasound, so focus assessment using ultrasound, but you really want to make sure and assess your patient first before you rush to do that. But that'll be one of the first things you can do if you have an ultrasound machine before you go to do radiographs. Potential for arrhythmia. Arrhythmia is 24 to 48 hours post-trauma. And this is very key for us to know. This is one of the questions. When I have patients that come to me and the surgeon says, this dog was hit by a car, it has a broken leg that we need to fix, I always ask, when did the trauma occur? How long ago did this trauma occur? Because I know if this trauma occurred within 24 to 48 hours, there's a potential for arrhythmias to develop because of myocardial trauma in these animals. So using a drug such as dexmedetomidine or alpha-2 or ketamine, NMD antagonists, may not be appropriate in these cases. So I want to know when that trauma occurred. Did anyone see what happened in that case? Because that's going to give me a lot of information, what drugs I think are safe or not safe to use in this animal. Once we've assessed our patient and we know what's happening with our patient, then you're going to administer your pain meds. Because if you administer your pain meds too quickly, if the animal has a neurological deficit, then we may miss those because those may be masked by the use of your opioids. So you want to do a neurological exam, etc., everything first before you administer pain medication to these patients. I just want to talk about tramadol for a minute. Tramadol in dogs has been shown not to be effective. However, it has been proven to be beneficial in cats. The reason for that is because the M1 metabolite, so O-desmethyl tramadol, that's where the analgesia is really found, is really provided to these animals. Dogs don't make a significant amount of that O-desmethyl tramadol M1 metabolite. However, cats do. Some studies were showing that there's some benefit to having tramadol on board because for chronic pain, but newer studies are saying that it may not really even be beneficial for chronic pain. So tramadol in my use is not, I don't use tramadol in dogs, I don't recommend it in dogs because I don't think it provides any benefit for acute surgical pain, for acute pain. And based on some more recent studies, I'm also thinking now it doesn't really benefit animals in chronic pain. So I'm going to use other modalities for animals in chronic pain, such as gabapentin, galiprant, etc., other modalities, but I'm not going to use tramadol in dogs because all of the data that as I'm seeing so far really doesn't provide any benefit to dogs. Cats, on the other hand, do make a significant amount of that O-desmethyl tramadol. Problem in the US is we only have the oral formulation, and cats hate the taste of it. I know other countries have the injectable formulation, so I think it'll be beneficial for cats, but not for dogs. So what sort of protocol can we use for these patients? Acepromazine, again, is an option, but again, only if the animal is stable. If you have a patient that comes in shock, it's tachycardic, and it's hypotensive, then acepromazine is going to contribute even more to that hypotension, and therefore to that tachycardia, because that animal is trying to compensate. So acepromazine would not be a good choice at that time. However, if that patient is stabilized, then maybe 1 to 2 days later, blood pressure is normal, heart rate is more normal, and dog is a bit nervous, then acepromazine may be appropriate at that stage. But usually initial management of those cases, if it's a trauma that has to be rushed quickly to surgery after stabilized, somewhat stabilized, and acepromazine would not be appropriate. Alpha-2 adrenergic agonists such as dexmedetomidine, maybe xylazine, may be appropriate in these cases, but again, it's going to be dependent on your history, your physical exam findings. If does this animal have a murmur, does it have heart disease, then you may want to avoid alpha-2s in patients with any sort of cardiac disease. Opioids, yes, these animals are in pain. Ideally, they need pure mu opioids. Butorphanol would not be ideal for this patient. If pure mu's are not available, then buprenorphine should be administered if you have buprenorphine. If you have gabapentin, I would also administer gabapentin to these patients. Multimodal analgesia. So that's going to be my goal. If I don't have the opioids that I think I need for these patients, then I'm going to use something like multimodal analgesia. So I would use, as I said, perhaps a non-steroidal. Once the patients are stable, because if a patient's hypotensive, I'm not going to want to give a non-steroidal. So I'm going to give buprenorphine if that's the best opioid that I have. I'm going to give other things. So as I said, gabapentin and the other modalities that provide multimodal analgesia. I may even use a lidocaine CRI. Lidocaine is not only useful for treating arrhythmias, Lidocaine has many properties. Lidocaine has antiseptic properties, has anti-inflammatory properties, has MAC sparing properties. So lidocaine CRI can help to decrease inflammation and thereby provide some analgesia. And that'll be even maybe in the initial stabilization part before this animal comes to anesthesia. If I have a patient that's very hypotensive, however, I would avoid lidocaine until that animal is more stable. So for induction for these cases, propofol works great. Propofol plus a benzodiazepine. So you see a trend here. I use benzodiazepines in almost every single one of my cases because I think benzodiazepines are beneficial in that they decrease how much propofol I need or how much alfaxone I need or how much ketamine I need. They provide some sedation, and they're really good drugs, and they're cardiovascularly sparing drugs, essentially. So they're really good drugs, I think, to use in these cases. Propofol plus ketamine, again, it depends on the window, right? If we're within that 48-hour window, I tend to avoid ketamine. If the animal has a history of heart disease or auscultator murmur, or we get an echo and we see the animal has heart disease, then I would avoid ketamine in those cases. If not, propofol plus ketamine works great because ketamine, as we said, is an NMD antagonist, so it's going to help provide additional analgesia to a patient as well. Ketamine plus a benzodiazepine is also very beneficial to these patients, assuming there's no heart disease. So just remember, heart disease, brain trauma, brain lesions, ketamine and alpha-2s are I don't like to use those drugs in those cases. For maintenance of anesthesia, inhalant and oxygen, so isoflurane and oxygen, sevoflurane and oxygen, perhaps even desflurane and oxygen, depending, you can use that. Fluid therapy, LRS, lactated ringer solution in dogs, you start at 5 mils per kg, cats at 3 mils per kg. If blood pressure is a bit compromised, I would consider giving a bolus of crystalloids to these animals. Some of these cases with these fractures, these animals may not be they may still be somewhat hypotensive. So this may be a day or two later. Usually we stabilize them really well, but you can still see a bit of a compromise with that, especially with your drugs, as we said, that have an effect on the cardiac system. So the heart may not be able to contract as well because just of the anesthetic drugs. So if these patients are a bit hypotensive, I would consider doing a dobutamine CRI. I would consider giving ephedrine. Ephedrine is another drug that can help with blood pressure. So 0.1 to 0.2 mg per kg of ephedrine IV is beneficial, or even dopamine. CRI, concentrated infusion, will be beneficial. Norepinephrine is not my go-to drug for these types of cases because usually these cases are not that sick and hypotensive due to sepsis, as we spoke about for, say, Pyometras. So for this sort of case, blood pressure support, fluid therapy, dobutamine, dopamine will be appropriate to maintain blood pressure in these cases. And so we need to talk about multimodal analgesia as well. Multimodal analgesia, regional blocks are really good in these cases. So an epidural, femoral sciatic nerve block, brachial plexus block can also be used in these cases. And we'll talk about that a little bit more in a second. I just want to talk about this drug as well, Nocida. I don't know how many of you have seen it or heard about Nocida, but Nocida is essentially bupivacaine and liposome injection suspension. It's effective, so it's once you administer it to a patient, and it's usually placed within tissue layers, it provides analgesia for about 72 hours, so for about 3 days. It has been shown to be safe in dogs. It has also been used in cats. We use it a lot for many, many cases. So it is a good drug. It's somewhat expensive, and it may be difficult to get in some places. But you can use Nocida for a fracture repair, for example. So you put in this tissue around the fracture. Once you're closing, it provides very, very good analgesia for up to about 3 days. Epidurals are very effective for animals with trauma to their back end, so hind limbs, tail, perineum, that area. So you essentially put your needle between L7 S1. And in these cases, if it's a fracture repair, I will use a local anesthetic. such as lidocaine or bupivacaine or ropivacaine, plus an opioid, morphine, buprenorphine. Morphine, because it's not a very lipophilic drug, it stays within the epidural space longer than the other pure MUs. But again, you want to use preservative-free drugs and drugs that are deemed safe to be used in the epidural space because you don't want to cause any damage to that spinal cord. Epidurals are something that is pretty easy to learn and can be done in multiple practices. Brachial plexus block is really used more for things that are around the elbow and distal to that. Mid-diaphyseal fracture or proximal fracture in the humerus, I still consider doing it, but it's usually not that effective in fractures or lesions that are high up on the bone, usually kind of like elbow down. Brachial plexus blocks take a little more skill and training to do. I do not recommend doing them blind. I'd recommend you can either use a nerve stimulator or ultrasound as the gold standard. So you put your ultrasound probe on there, you find the nerves, and you block around the nerve. And that really provides excellent analgesia to these patients. Here you can see a block that's been done a little bit higher. It's actually a subscaling block. And these blocks work a lot better because they block more of the area. And they block really well, that area really well. What you have to be careful with doing a brachial plexus block is you can get blockage of the phrenic nerve. Phrenic nerve is going to supply a diaphragm. So if I have an animal with bilateral fractures, or maybe I'm scoping elbows on both legs, I only block one side, usually worst side, because I don't want to risk blocking the phrenic nerves bilaterally. Okay, so here you can see an image of a nerve stimulator. And what that does, that actually helps you figure out how close you are to the nerve. Because you don't want to be within that nerve sheath when you're administering your drug. You want to be just close to the nerve. So that nerve stimulator really tells you how close your needle is to that nerve. Ultrasound is going to show you exactly where your needle is in relationship to the nerve. And again, you want to infuse the drug around the nerve, but not within that nerve sheath. So brachial plexus block, really good for things, kind of distal humerus, but require more training and skill to do than versus something like an epidural. And then there's a femoral sciatic nerve block. Femoral sciatic nerve block, I think, are better than epidurals because, again, you're blocking specific nerves and you're just blocking that leg, that one leg. With an epidural, both hind limbs get blocked. So motor function is lost for both hind limbs. Depending on duration will be dependent on what drugs you use. Whereas a femoral sciatic nerve block, you only block that one limb. So when that animal recovers, that animal can still use his two front limbs and his other hind limb to get around. Again, femoral sciatic nerve block should be done with a nerve stimulator, or gold standard will be ultrasound. Requires more training and more skill to do, but it's a really nice block to do. In terms of blocking your femoral nerve, there's always a risk of hitting that artery. Femoral artery is located very close there. If lidocaine happens accidentally to go systemically, that's not a problem in terms of life of the animal. If bupivacaine goes systemically, bupivacaine is highly cardiotoxic and should never be administered systemically. So if bupivacaine goes systemically, that's going to be a big problem for that animal. That animal can arrest, can have cardiac arrest. So again, skill, experience, and ultrasound or nerve stimulator guided are the ways you want to do a femoral sciatic nerve block if you do decide to do this sort of block. And just to end off, I just want to remind everyone that a checklist is key for everything that you do. You want to go through that checklist, get your signalment on your patient, history, physical exam, have all that information before you proceed. We also have a safety checklist for every single patient going under anesthesia. That safety checklist has the patient's name on it, ID number on it to ensure that we actually operate on the correct patient. So that safety checklist is done before we do anything with that patient. So all that ID information must be there. We have to make sure that the owners, on that safety checklist, it also asks the surgeon, do we have owner consent? What leg are we operating on, for example, to ensure we operate on the correct leg? And anesthetic checks, do we have any safety considerations? So do we think this animal is going to need blood, etc. So all that is done before that animal is pre-medicated. Okay, so our safety checklists. So checklists are really key in management of these cases. And that's what I have for today.
Thank you, Dr. MUNOZ. That is a long marathon lecture. We enjoyed a lot. Very nice, and we got many practical tips for the anesthetics as well as analgesias. There is another compliment also throughout the lecture. There is a good connectivity and good speech without any echo. We have got, Dr. MUNOZ, we have got 235 questions, but I have limited to 10 or 12 because most of the questions are already answered by you during the course of the webinar. So we have selected 10 questions. Maybe there are some answers were there in your lecture, but to re-emphasize some of the points we are adding on.
Okay.
Yeah. You have been mentioning about cimicoxib. So after the procedures, can it be given before as a preemptive analgesic?
Okay, yeah, good question. So non-steroidals, so cimicoxib, non-steroidals, so that would also include Rimadyl, meloxicam, etc. The only times that I would consider giving a non-steroidal prior or the beginning of a procedure is if the animal is a healthy patient and I have no concern about this patient becoming hypotensive during anesthesia. So usually for maybe a castration or a spay or a orthopedic TPLO, so a simple ASA1, maybe ASA2 cases, if those patients are considered to be stable. If I'm concerned that these patients may become hypotensive during a procedure, then I will not administer the non-steroidal until the end of the procedure, assuming the patient did well during anesthesia.
Okay, thank you. Then, sir, you have been mentioning about line block. Will it affect the healing?
No, so that was a very good question again too. Multiple studies have been done in North Carolina State looking at the use of local anesthetics for wound healing, and it has been shown that line blocks do not affect wound healing, and it is actually beneficial for your patient. So you can use line blocks for basically any incision you're closing without worrying about delayed healing or increased infection or anything. The only concern that some surgeons have is that if you infuse too much of a volume at the end of surgery, it can sort of distort the tissue a little bit, so it might be a little bit more of a challenge to close. But if you do your line block initially on your approach, then there's no concern in terms of affecting healing of that incision.
Okay, thank you. Can you repeat about APGAR? APGAR, because they want to APGAR. On neonate you have been telling, isn't it? So they want a re-emphasize on that.
Okay, sure. So the APGAR score, as I said, was developed by Virginia APGAR in 1952, and she was a human anesthesiologist. And that APGAR score stands for Appearance, Pulse, Grimace, Attitude, and Respiration. What that APGAR score looks at is at birth, human babies get that score, and it really determines the viability. How stable, how viable is that creature at birth? There's a modified APGAR score that we use in veterinary medicine for dogs. And so essentially, you want to look at all those parameters on there, and that gives you an idea of how well that patient, that neonate is doing at birth. So if you have a high APGAR score, it's likely that patient should do well. If they have a very low APGAR score, then that patient may require more stabilization and more treatment and more monitoring to get up to the point where it's ready for discharge.
Yeah, thank you. Does propofol have contraindication in the brachycephalic drugs, brachycephalic breeds?
Which drug is that?
Propofol.
So does propofol have contraindications in brachycephalic breeds? Is that your question?
That was the question, yeah. Do propofol have contraindication in brachycephalic breeds?
So I would say no. It does not have, it's not contraindicated in brachycephalic breeds. However, one caveat to that is that when you administer propofol, your patients may become apneic, especially if you give it too quickly. So you must be ready to intubate these patients once you administer it. What I found is very useful is to have a stylet. And because sometimes brachycephalics can be a little bit difficult to intubate. So a stylet actually will go into the airway first, and then your ET tube kind of feeds into it. So I would say propofol is not contraindicated in brachycephalics, but be aware they may become apneic, and you must be ready to secure an airway and intubate them after you administer it.
Okay. So what is your recommendation for the dogs, azotemic dogs with Pyometra?
So azotemic dogs with Pyometra, those dogs need to be managed first. They need to be stabilized as best as you can. So why are they azotemic? Is it a pre-renal azotemia? Is it a renal azotemia? Is it a post-renal azotemia? So you want to try and assess the reason for the azotemia. And then really you want to administer fluid therapy to these animals to try and correct that azotemia. And before you take them to surgery, if there is a renal azotemia, then you want to ensure that you maintain your blood pressure at a normal blood pressure to try and ensure that you have renal perfusion, appropriate renal perfusion for those cases.
Okay, sir. So what pain medication can be given on subsequent days of C-section to alleviate pain?
Yeah, very good question. A lot of times the suckling and stuff of the puppies from the dam kind of helps provide their own sort of endogenous pain relief for opioids. We tend not to give a whole lot of drugs to these patients. So usually one dosage of non-steroidals really helps maintain that analgesia for these animals. Because you have to think, if you give these patients opioids, the opioid may cross into the milk and maybe may affect the puppies. So there are studies which are currently underway, I believe, looking into the aspect of using Nocida at the incision line. So I think the epidural that we do post anesthesia with morphine or buprenorphine that's safe to use is going to provide analgesia for that dog. Your non-steroidal, if you do that at the end, it's going to provide analgesia. That's what we really use right now for these cases. And most of these dogs really tend to do well. One thing I didn't touch on is pain scoring, but it's something that we should do to all of our patients. So you pain score your patient when your patient comes in and before you discharge your patient. So that's going to give you an indication of how well your analgesics are working. But for these C-sections, that's basically what we're doing right now to help manage their pain. So epidural of morphine, we give a systemic opioid as well once all the puppies and kittens are out. And then if you think appropriate, a non-steroidal at the end, or once they're awake.
Okay. So we get various sedative levels while using midazolam. Any restriction for using midazolam?
In what case?
Yes, given its general use.
So you're asking, is there any contraindication given midazolam to dogs?
Yes.
So I use midazolam, as I said, for most cases. Many cases, I would use midazolam as a co-induction agent. If you give midazolam as a pre-med in a healthy adult patient, you can see a paradoxical excitation. So sometimes the animals will get very excited if you give it intramuscularly as a pre-med. So I tend to avoid giving midazolam as a pre-med into anything that's healthy. If it's a very, very, very sick animal, a very young animal, then midazolam as a pre-med works well. But once it's a young, healthy, or adult healthy animal, midazolam as a pre-med is not a contraindication, but you can get this paradoxical excitation that you really don't want to deal with. If I have a patient with a shunt, so intrahepatic or extrahepatic shunt, I also tend to avoid benzodiazepines. And in C-sections or dystocias, I also avoid benzodiazepines because in humans, it has been shown that the benzodiazepines, you get ion trapping. So the drug kind of gets trapped within the placenta, within the uterus, and it can decrease the APGAR score in humans. There's not many studies done in veterinary medicine looking at that. So because I don't know exactly how the benzo is going to work in small animals, for a C-section or dystocia, I avoid it in those cases. But if I have a case, usually any other case, so a fracture repair, brain lesion case, soft tissue procedures, otherwise than what I mentioned, I tend to use benzodiazepines in those cases.
Thank you, sir. Thank you very much for sparing your time. Of course, we have been going from 7 o'clock to 8:45, 1 hour 45 minutes. That's a great. Thank you, Dr. MUNOZ. We have Dr. Balasubramaniam, Director of Clinics, who is the organizer and the key pivotal role in organizing webinar. He is on the line, I think. May I request Dr. Balasubramaniam, Director of Clinics, Tamil Nadu Veterinary Animal Sciences University, to have the conclusion address, please. Over to Director of Clinics. Sir. MUNOZ sir, we may disturb you again depending upon your freeness. So hope you will be free as and when you're free. We'll be disturbing you for yet another webinar or to discuss at least exclusively for PG students.
Sure.
Yeah. Thank you so much.
Absolutely.
Yeah. So, Director of Clinics, we are waiting for you, sir. Maybe you can unmute your mic and then please join us. Dr. Santosh, can you let him?
Hello.
Dr. Santosh, can whether Director of Clinics is on the line?
Yes.
We are waiting for you, sir. Thank you.
Is it audible? Am I audible?
Yeah, you are audible, sir.
Okay. Thank you, Dr. Arun Prasad and Dr. Vijay Kumar. At the outset, I have to congratulate Dr. KIRK MUNOZ for a very nice presentation, which was illustrative, informative, and interesting.
Thank you.
So I think we have called the right person to have the webinar on this World Anesthesia Day commemorative session. So we are very happy and for having accepted our invitation and having given the webinar. Now, I'm sure that the participants, both the students, faculty, and the field and practicing veterinarians would have been benefited because it was very informative. Because I am basically a gynecologist, a large animal. So the features which you had told in all the aspects covering from the small animal cesarean section, because initially I had worked for a period of time in small animal gynecology. So it was very interesting. The points which I think they have a lot of carry home message. And I'm sure that this anesthesia topic is like an ocean. Otherwise, one has to go through each and every part, as you said, in cesarean section, in brain lesions, or like that, in a condition-wise, like trauma, especially fracture management during that time. So all these things people have to take care. And I'm sure that this would have been a very, very interesting and informative session for the students as well as the practicing veterinarians. As Dr. Vijay Kumar told, I think maybe at a later date, depending on your convenience, we would like to again pull you up for a lecture to address specifically our constituent college students and faculty. Because as you know, today, I don't know whether it has been mentioned, today the number of participants is over 1,000. And the interesting part is more than 30 countries other than India, the participants are there. So you have become, what to say, a very popular person.
Very honored.
Yes. So maybe after the completion of the webinar, we would like to send you the report, which you can go through, like how many people have participated from which are those countries. So I think it was a real success and it was conducted in a very elegant manner. And as I think you asked a question to Dr. Vijay Kumar, whether there will be any interruption, because in Google and other platforms, Zoom, normally you have this interruption. But fortunately, we have been organizing this webinar a couple of times with Microsoft Teams. And I have to congratulate the Alembic Pharmaceuticals, Mr. Karunanidhi, and his entire team led by Dr. Santosh Shinde, who made it very meticulous. So there is no flaw anywhere. I think maybe for a brief period, maybe less than 30 seconds, there were like a slight disturbance. But otherwise, it went on very smooth. And thank you. And I would like to thank all the participants for participating in this webinar. But first of all, I have to thank our Honorable Vice Chancellor, Dr. C. Balachandran, who has given all the support and who has been present here to give the inaugural address in this World Anesthesia Day webinar. It was unfortunate due to slightly I'm indisposed, so I could not make it in person. So from home, and I'm giving this concluding remarks. Anyhow, thank you very much. Thank you once again, Dr. KIRK MUNOZ.
Thank you very much.
Thank you, sir. There is a vote of thanks to be proposed by Dr. Ramesh. I call upon Dr. Ramesh.
Good evening, sir. For the participants from India, almost good afternoon for the participants from African continent, and almost good morning from good morning for our participants, those who are participating from America, North American and South America continents. We have come to a conclusion of the successful program. I express my gratitude and thankfulness to Honorable Vice Chancellor of Tamil Nadu Veterinary Animal Science University for giving necessary permission and conduct of this successful program, and for his special address on this occasion. I express my gratitude to international speaker Dr. KIRK MUNOZ for his kind acceptance to deliver in this global webinar. I thankful to our beloved Director of Clinics for all his support and encouragement for the successful conduct of this program. I thankful to all our deans of Constituent College of this university, and the successful webinar program could not have been completed without mentioning the name of Mr. Karunanidhi and Dr. Santosh from Alembic Pharmaceutical for their support. Our special thanks goes to all of our faculty and students from this university, and faculty and students from all over the world. Our special thanks to veterinary practitioners who are all participated in the webinar from different parts of the country. We thank Dr. Vimal and Dr. Tirunavukarasu for their unconditional technical support. Finally, almost 1,037 participants have participated in this program from 7 continents. Unfortunately, we are unable to get the participants from Antarctica. Other than 5-6 continents, we are able to manage the participants to participate in the program. From North America, USA, Canada, some of the countries I would like to enumerate here. From South America, Brazil. From African continents, Kenya, Jamaica, Somalia, Egypt, Rwanda, and Oman. From European continent, Poland, Portugal, Spain, Bulgaria, Czech Republic, and Hungary. In Asian, you know very well that we most of the participants from Malaysia, Philippines, and Nepal. From Australia, we have some of the participants participated in this program. Unfortunately, we are unable to get a person from Antarctica. We hope that we will do the next time, sir. Thank you very much, and thank you for everything. Thank you, sir. Thanks to one and all. Thank you, sir.